So let's shift gears to the concept of phobias. Now, what is the difference between a fear and a phobia? Well, if I were to answer it, the first thing I would say is that a phobia is a more extreme fear reaction than is normal. A phobia defies rational belief. So, a person who, let's say, is afraid of spiders is not going to distinguish between a spider that is harmful versus a garden spider in that they discover in their garage. Any spider is going to induce anxiety. Now, people with phobias, one of the hallmark features is that they avoid whatever the object or situation is that's linked to the phobia. So if a person is afraid of spiders or has a phobia for spiders, better yet, they're going to try and avoid spiders at all costs. So they might run out of the room, they might jump on a table, whatever it might be, to get away from whatever spider they saw. And when we talk about spiders, or that's just one example of a phobia. If you can think of it, it is a potential phobia. So some people have a fear of confined spaces. We refer to that as claustrophobia. Some people are afraid of dogs, called cynophobia. Now, an interesting finding with cynophobia is that the vast majority of people who are afraid of dogs have never been bitten by a dog, but they're afraid of dogs anyway. And you might ask yourself, well, why? Right? And we'll get into it. Agoraphobia. Agoraphobia is now its own distinct disorder. It is separated out in the DSM-5 from all the other phobias because of how profound the impact is on a person. So agoraphobia is a fear of places where it's difficult to escape. So if a person is stuck in a big crowd and they have this induced anxiety, they may avoid crowds because I can't get away. In the most extreme scenario, a person's fear of being outdoors or in open places or inescapable places is so extreme that they don't leave their home. So the classic case that people present is where a person is homebound. So how do you treat a person who has agoraphobia if they're never going to leave their home? Well, that is one of the beautiful things about virtual therapy is we can do therapy with a person from their home. Or in some cases, it's not uncommon for a clinician to go to the home of the person, of course, with their consent, and work with them where they're at. And then, of course, there's social phobia. Now, social phobias are distinct as well, right? Because it's linked to a social situation or condition. So we'll talk about the general categories of specific phobias, social phobias, and agoraphobia distinct. So as I said, well, what's the difference between a fear and a phobia? Well, a fear is a normal reaction to a threat, right? So phobias tend to be more extreme. There is more avoidance. You'll go out at great lengths to avoid that feared object or situation, and it causes some level of distress when being exposed. So if you were to look at fears and phobias, there are some patterns, right? Things that are more evolutionarily wired, we tend to have greater fears in general, but greater phobias as well of, for example, animals. If I mentioned spiders, I mentioned dogs, but Why is it that human beings are so afraid of animals? It could be snakes, it could be anything. The answer is simple. The way we live today is not how we lived through time. For a long period of time, we lived in nature with nature. And that's important, right? So for thousands of years, we lived with spiders being right there. We lived with snakes being right there. We lived with the lion being right there. And through time, we put it into our DNA. We need to worry about animals. Now, that is much greater than something like being alone. People have anxiety about being alone. People have phobias of being alone. But the threat is much greater when it comes to animals than, let's say, being alone. So, as I said, we have specific phobias, and then we have, more broadly speaking, two broader phobias: social anxiety disorder, which is called social phobia, and we have agoraphobia. So let's talk about specific phobias first. A specific phobia is exactly that. There is a identified trigger for this phobic response. Another example of a phobia is clowns. Some people have a profound fear of clowns. Now imagine your niece or nephew has a birthday party and the parent wants to hire a clown. Well, a person with a fear of clowns may not show up at that party. And if they do show up at that party, they're going to have a heightened level of discomfort or distress. So the general diagnosis for phobia, we have to have a marked, persistent fear that is objectively excessive relative to the threat. It has to be a chronic condition of 6 months or longer. I mentioned that exposure induces some kind of avoidance behavior, and a person knows that this is problematic, knows it's excessive, but if they can't avoid it, they have intense anxiety, and it interferes with their functioning. Now, some phobias, it's easy, right? It's easy to avoid clowns because clowns, generally speaking, we don't have day-to-day interactions with. But imagine you worked at a circus and you were afraid of clowns. Well, that's going to be a problem. That's going to be an occupational problem. So that's going to result in the need for treatment more, right? With agoraphobia, which is its own type of phobia, that's going to interfere with the ability to go to work, go to school, pick up one's medication if it's necessary, and so forth. To be homebound is very hard. So there are some forms of phobias that are more extreme than others, that require more targeting than others. So that's specific phobias. What is the epidemiology of a specific phobia? We see about 8+% in a given year and about 12% across the lifespan. And we know these numbers are low. We estimate the real percentage to be about 25%. So you might say, well, why is that? Very few people are going into therapy because of a fear of spiders, right? Uh, very few people are going into therapy because of fear of like holes in the wall, like those little pores. It just isn't the case. So there are a lot of phobias that we can avoid and not go into therapy for. So we know it's really about 1 in 4. We know the rates are higher amongst women, higher amongst ethnic minorities. Again, you could conjure up some sociocultural explanation for that. Now, social phobia is only linked to a social performance or a social setting. And what is the fear? The fear is linked to real or imagined embarrassment. So notice real or imagined embarrassment. So you have to perform and you're worried about someone criticizing you or being humiliated. Again, it's a chronic condition, social phobia, and it's usually triggered by social situations exclusively. So, similar to other phobias, there's profound avoidance behavior, there's a recognition that the reaction is more extreme than is warranted. And when forced to confront the phobia, it causes intense anxiety or distress. So imagine being a CEO of a company and having to or having to present quarterly projections for the company and having social phobia, right? That's going to be something a person might come into treatment for versus another person, they might just avoid public speaking and never come into treatment. So, the epidemiology of social phobias, we see that it's about 7% for a given year, 12% across the lifespan. And we see it's 1.5 times more prevalent amongst women relative to men. Again, ethnic minorities have higher rates in this particular case. Asian Americans and African Americans tend to have higher rates than other ethnic minorities. And once again, it shows up in adolescence and early adulthood. Now, this is showing up in adolescence and early adulthood. That makes sense, right? It's showing up a little bit later because your need for social approval increases markedly when you hit puberty in adolescence. Trying to figure out who you are and how you fit into your peers, of course, there's a social anxiety linked to that. And in early adulthood, when you're trying to date and find a romantic partner to settle down with, there's anxiety in dating that's linked to social phobia. So it shouldn't shock you that these conditions manifest themselves usually in adolescence or early adulthood. Once again, like other conditions, that doesn't mean it can't occur in childhood and it can occur later in middle or late adulthood. It's just the most common case is adolescence and early adulthood. So let's try and explain phobias. What is driving phobias? From a behavioral point of view, we're going to look at conditioning and modeling, right? So classical conditioning, when you pair two stimuli together, you can induce a phobia. So there are some people are afraid of running water, right? So we aren't wired to be afraid of running water. But if we were to pair running water with being trapped, we could wire or create a fear response to water. Remember in Pavlov's study, we had preconditioning, conditioning, and post-conditioning. So if I were to condition or pair running water with feeling trapped, eventually you're going to learn that association and develop fear. This is just one example, right? But there are many ways that classical conditioning can take place. Another example is modeling. I mentioned that the vast majority of people are afraid of dogs, have never been bitten by a dog. So you have to ask yourself then, well, why is a person afraid of dogs if they've never been bitten? Simple. It's possible that other people in their life demonstrated a fear of dogs. And through observational learning, you said, well, if they're afraid of dogs, I have to be. So let's say mom crosses the street when she sees a dog, you learn that dogs are to be afraid, to be feared. Now, how do behavioral explanations justify generalized anxiety disorder? The answer is stimulus generalization. So one phobia leads to another phobia, which leads to another phobia. Ultimately, it can be generalized and become more global. So from a behavioral point of view, a phobia could lead in principle to generalized anxiety disorder. We also have to understand from a behavioral or evolutionary point of view why some phobias are more common than others. And we refer to this as preparedness. So we're predisposed to develop some fears over others. And I picked examples of animals like snakes and spiders because they were on the far right of the graph when I introduced phobias, right? So why are we more afraid of snakes and spiders than, let's say, faces or houses? The answer is twofold. From an evolutionary point of view, we're wired that way. So some people say we altered our genetic expression. So we're wired in our genes to be afraid of snakes and spiders. As I explained, we've lived in these environments that were less divided or protected historically. So our genes might have been altered. From a behavioral point of view, they refer to as something called environmental preparedness, which is our environment or setting tells us it's important to be afraid of some things over others. So even if it's not in our genes, we're shaped by our environment. Whoop, shoot. Okay. So how do we treat phobias? Well, there are many different treatments of phobias. A common one is exposure therapy. So exposure therapy is where you present a client with whatever their phobia is. And you can do it in many different ways. You can do it as a gradual process called systematic desensitization, where we develop a fear hierarchy and we expose you to something that is low on your fear hierarchy and then work to your more extreme fears. And as we teach you to relax, the exposure to the feared object is carried over to the more extreme scenarios. So let's take a spider. I might ask you to rank all the things linked to spiders that you're afraid of. A picture of a spider, a toy spider, a movie that includes spiders in it, or a real spider. So if I were doing systematic desensitization, I would start with the picture because that's lowest on your fear hierarchy. When your anxiety drops to a reasonable level, then I might expose you to a toy spider. And then we work on relaxation. And then when your fear drops again, then we'll deal with a physical spider, a lifelike toy. And then ultimately, I might have you handle a spider. But notice it's a gradual exposure technique where we work you up to the most extreme. Now, exposure therapy can be in real life or it could be imaginary. So if I'm actually introducing you to the spider, that would be in vivo desensitization. Versus if I ask you to imagine you were holding a spider right now, that would be covert desensitization. But whether it's in vivo or covert desensitization, from a systematic desensitization point of view, it's gradual from low to high in exposure. Whereas flooding is the exact opposite. Flooding is you expose a person to the most extreme form of their fear right from the beginning to teach them that there was no real rational reason to be afraid of that spider. So similar to fear factor, we might have a person interact with many spiders right from the beginning. The problem with flooding is that people usually fight against that model. They prefer systematic desensitization because it's gradual. Counterintuitive, though, flooding actually is a more effective model. Another way of exposure is through modeling. So instead of you handling a spider, I might handle a tarantula in front of you, and showing that if I can handle this tarantula and I'm fine, you're going to be fine too. Related to, again, one of these techniques that required a lot of money originally is virtual reality. It used to be only the most sophisticated labs would use VR therapy to simulate a fear. But now we have Meta, right? So we have the goggles, the VR goggles. We have Samsung, who has their own VR goggles. We have Apple, who's coming out with their own VR goggles for a couple $100. So VR therapy is become pretty cheap, which we use for phobias. And I'll talk to you when we get to PTSD. VR therapy is used a lot with PTSD. What about social phobia? So if you're going to treat a social phobia, you have to understand what is driving the social phobia. So if it's related to social skills, we might try and say, okay, well, what is the anxiety? A person could feel overwhelmed in a social setting or not know how to engage in social conversations. So depending on what the issue is, we're going to target it differently. So if it's just anxiety being in social settings, we're going to teach you regulation techniques. If it's not having the social skills to start a conversation, we're going to teach you how to develop those social skills. And we're going to perhaps engage in some role playing or exposure therapy to teach you how to acquire those social skills. Now, in terms of medication, unlike generalized anxiety disorder, where benzos are used, we usually don't rely on benzos for a social phobia. So antidepressants, those SSRIs or SNRIs, are going to be used more than benzos, and they tend to be more helpful. From a cognitive point of view, we use rational motive behavioral therapy. That's Albert Ellis's model again, to like remove irrational belief sets or assumptions, the faulty thinking. Now, you might have heard CBT. So cognitive behavioral therapy combines addressing the irrational beliefs with the behavioral techniques. And I talked to you about social skills training already. So where if it's that you don't know how to interact appropriately in a social setting, we might practice in therapy. And then there might be role playing. We might do a social skills group. It might include two people having a role play conversation and getting feedback from other individuals. And then after you feel comfortable with the role play scenario, then it's generalized to one's natural environment. So that is phobias. Now, I'm going to once again stop the recording here.